Welcome to the systemic pathology. The first chapter in the systemic pathology is the cardiovascular system. All the topics in systemic pathology are very interesting, my friends. Especially it's the cardiovascular system which is very close to my heart. So let us see various disorders in the cardiovascular system, starting from atherosclerosis, then the rheumatic heart disease, infective endocarditis, and the most important topic, ischemic heart diseases, and finally the cardiomyopathies. So let us begin the topic with the blood vessel disorder, actually atherosclerosis, nothing but hardening of the arteries. Normal happy blood vessels will have a wide lumen. The lumen will be wide enough and the organs will be well supplied with the blood. What happens in the atherosclerosis is the damage to the tunica intima. There are three layers for the heart as such: the tunica intima, the innermost layer, the tunica media, the thickest layer of the vessel, and tunica adventitia. So the disease atherosclerosis is predominantly a disease of the tunica intima. The endothelial cell injury is the most important cause for the onset of atherosclerosis. So this is how the normal blood vessel will appear. This is how the atherosclerotic vessel will appear. So the organ in which this atherosclerosis is taking place, it cries because of lack of blood supply. So the demand will be more, the supply will be less, because the lumen will get narrowed. The lumen will get narrowed and the organ will suffer from loss of blood supply. This is what happens in a patient dying from myocardial infarction. Very commonly, the coronary arteries will undergo atherosclerotic narrowing. More the narrowing, lesser and lesser will the blood supply to the heart. We know heart supplies the blood to the entire body, but heart itself needs a good amount of blood supply. That is done by the coronary arteries. So if the coronary arteries show critical narrowing by atherosclerosis process, then heart will suffer from ischemia, loss of blood supply resulting in ischemic death of cardiac muscle fibers. Ischemic necrosis will take place, cardiac muscle fibers will die. That what we call it as heart attack. So let us see this atherosclerosis in detail. Atherosclerosis is actually a part of arteriosclerosis, hardening of the arteries. The other two types of arteriosclerosis are Monckeberg's medial calcific sclerosis. Very commonly we come across this Monckeberg's medial calcific sclerosis in the uterine blood vessels in the atrophied uterus. So as the age advances, the uterus undergoes atrophy. The blood vessels in the myometrium, they show this very peculiar type of calcification in the tunica media. It is a tunica media disease. Monckeberg's medial tunica media will show thick calcified deposits, calcific stenosis. And disease of the small arteries and arterioles is the arteriosclerosis, very commonly seen in patients who are having uncontrolled hypertension and uncontrolled diabetes. So hypertension and diabetes are again very much prone for this arteriosclerosis. They can suffer from various pathies, glomerulopathies, nephropathies. It is all because of this arteriosclerosis. So atherosclerosis is predominantly a disease of the tunica intima, characterized by formation of atheromas. Atheromas are the one which will contain predominantly a cholesterol material, and they are the one which will protrude into the vascular lumen and obstruct the blood flow. It affects predominantly the elastic arteries like aorta, carotid arteries, and iliac arteries, and even medium-sized muscular arteries like coronary arteries very commonly get affected by the atherosclerosis, including even popliteal arteries. So the final result of atherosclerosis depends on which vessels are get affected. For example, if the coronary arteries, patient will have a myocardial infarction. If it is a carotid arteries, patient will have a cerebral infarction, that is, patient can have a stroke. If it is a popliteal artery, patient can have a gangrene, say dry gangrene of the lower limbs. So it all depends which portion of the artery has shown the atherosclerotic changes. Various hypotheses have been proposed for atherosclerosis onset. but very much well accepted is Rudolf Virchow's response to injury hypothesis. He described it as atherosclerosis is an inflammatory process and it is a response of the endothelial cells to the injury. So it is a chronic inflammatory response of the arterial wall which is initiated by the endothelial cell injury. The lesion will progress by interaction between the modified lipoproteins, the macrophages, T lymphocytes and even smooth muscle cells of the tunica media. So what are the injury stimuli for the blood vessel? It could be due to the cytokines, which are a part and parcel of inflammatory cell mediator will be releasing these cytokines. It could be due to the bacterial products, hemodynamic forces like hypertension, it damages the vessels. Lipid products, viruses, complement factors and even hypoxia, advanced glycation end products which you will see in enormous quantity in diabetic patients. Other causes for endothelial cell injury also are there. So remember, normal endothelial cells are the one which will maintain the permeability barrier. So they actually normally they elaborate the anticoagulants, antithrombotic and fibrinolytic properties. So it maintains the normal homeostasis. It also elaborates the prothrombotic substances. It also produces extracellular matrix and it shows both vasoconstrictive properties and vasodilative properties, and it maintains the inflammation and even the cell growth. So normal endothelial cells are the ones which are required for the normal integrity of the blood vessels and normal flow of blood. As a consequence of endothelial cell injury, there will be more and more ablation of the extracellular matrix, more production of the cytokines and chemokines, growth factors will be released in excess quantity, vasoactive mediators will be released and even coagulation proteins will be released. So it is all because of the endothelial cell injury. With the endothelial cell dysfunction, there will be increased permeability, adhesion of the both platelets as well as the macrophages will take place over the endothelial cell injury wherever injury has taken place. So see this diagram is all the disease of the tunica intima. So tunica intima is so much widened. It's all because of these endothelial cell injury have suffered from, they have undergone injuries. So wherever there is an injury, this particular injurious site, it makes adhesion of the WBCs, mainly the monocytes and even platelets, and they will enter inside. So they transmigrate across here, the endothelial surface, and they will eat the excess amount of fat that's get accumulated here in the tunica intima. After phagocytosing this fat, they will become foam cells. The fat can be so much enough that it can even form the cholesterol clefts. The fat is predominantly lipoproteins and even triglycerides that is accumulated. It's LDL that is accumulated in the tunica media. It is so tasty that even smooth muscle cells in the tunica media, they will migrate to the tunica intima. So these are smooth muscle cells migrating to the tunica intima and they are also eating the fat and they are also becoming foam cells. So when I use the word foam cells, it is foamy macrophages as well as the fat laden smooth muscle cells. For both we call it as foam cells. So this is how the atherosclerotic plaque will appear microscopically. There will be a central necrotic center, there will be inflammatory cells, predominantly macrophages, lymphocytes and even smooth muscle cells which are appearing as the foam cells. As the smooth muscle cells will migrate to the tunica intima, so the tunica media, it loses its thickness, the thickness will be lost, and that's how such a vessel are very much prone for aneurysms. Abnormal dilatation of the vessel is the aneurysm. So such a vessel, because of loss of its tunica media, that's the one which is the thickest layer, that will be lost because of the smooth muscle cells are migrating to the tunica intima. So aneurysms are very much common as atherosclerotic complications. So let us have a look here. It's oxidation of the lipoproteins will take place. There will be accumulation of more and more lipoproteins, especially it's low density lipoproteins will take place in the tunica intima. Monocytes will adhere, macrophage will migrate across the endothelial surface and they become foam cells after engulfing, phagocytizing the lipoproteins. Platelets also will adhere at the site of the endothelial cell injury. So once the platelets are there, once the macrophages are there, they keep on releasing various growth factors, various cytokines, and these cytokines will attract the smooth muscle cells to the tunica intima. So there will be a migration of smooth muscle cells to the tunica intima. There will be a proliferation of smooth muscle cells in the tunica intima. So more and more elaboration of extracellular matrix proteins will take place, and as the time advances, there will be enhanced accumulation of the lipids in the tunica intima, sometimes even intracellularly as well as even the extracellularly. So let us see the epidemiology of the atherosclerosis. There is a huge dramatic increase during the last 5 decades. There is high incidence of patients dying from myocardial infarction. So in US as such, the incidence is appearing to have been peaked, but now it is gradually declining because of the awareness about the myocardial infarction and about the risk factors and how to prevent these risk factors. Whereas still in India and UK and other countries, atherosclerosis incidence is still at a higher level. It is continued to increase. So let us understand what are the risk factors for development of the atherosclerosis. So risk factors have been classified into non-modifiable risk factors and modifiable risk factors. Non-modifiable in the sense you cannot modify these factors, like there are major factors and lesser or uncertain factors. Major factors like increasing age. As the age advances, atherosclerosis becomes very, very common, so you cannot prevent aging process as such. Male gender, if you're born male, you cannot change your gender easily. Family history of atherosclerosis, again you cannot alter it. Various genetic anomalies have been described that will makes humans to prone for development of the atherosclerosis. Probably lesser or uncertain role will be there for obesity because there will be hypercholesterolemia status. Physical inactivity, that again makes the patient to prone for atherosclerosis at the early age. Type A personality, that again, and stress factors, they are very contributory factor for atherosclerosis. The incidence is said to be almost equal in the postmenopausal woman, whereas during reproductive age, females are said to be protected because of the estrogen levels. Probably at the postmenopausal age, incidence of atherosclerosis is same for male as well as for females. High carbohydrate diet is again probably a contributing factor. What are the modifiable risk factors? This is the one what you need to understand, what you need to take care. Hyperlipidemia is again very much important and major risk factor. Hypertension, uncontrolled hypertension is again very much important risk factor for atherosclerosis as it damages the blood vessels. Cigarette smoking, that is the one which is almost 200 times it increases the risk of development of an MI due to the atherosclerotic narrowing of the coronaries. Diabetic status is again, it makes the person to develop hypercholesterolemia status. So these are the one which you can control and you can modify, right? Hypertension, you can keep it under control. Cigarette smoking, totally you can stop or quit it out. Diabetes, you can control your diabetes. Hyperlipidemia, there are lipid lowering drugs are available, can be used. So lesser and uncertain. So alcohol abuse, the lipoprotein, especially lipoprotein A, then saturated fat intake, and there is probably a role of infections also like chlamydial infections and even cytomegalovirus infections. So these are modifiable risk factor for the atherosclerosis. Hypertension is one of the very strong risk factor than even the hypercholesterolemia after the age of 45 years of age. Which parameter is more important, systolic or diastolic? Both. It's both are important. Both systolic and diastolic blood pressure are important. They increases the risk. So increased death rate have been described with the systolic blood pressure more than 140 and diastolic pressure more than 90 mm of mercury. Cigarette smoking, 1 pack cigarette per day for many years, that increases the risk of development of ischemic heart disease, myocardial infarction by 200 times. So that increases, that tells you that cigarette smoking is one of the very important risk factor for development of diabetes mellitus. It induces hypercholesterolemia. It also enhances the early onset of atherogenesis. Other factors with the diabetes being the increased incidence of MI, almost 2 times, increased incidence of stroke, and almost 100 times increased risk of gangrene, especially it's a wet gangrene in diabetic patients. Homocystinemia, that is increased levels of homocysteine levels. It causes endothelial cell dysfunction through formation of increased number of reactive oxygen species. The homocysteine levels are said to interfere with the vasodilator effect as well as the anti-thrombotic function of the nitric oxide. So hyperhomocysteinemia is usually caused by low folate intake and low B complex intake. So it can be prevented by taking good amount of folic acid as well as the vitamin complexes. Let us see how the atherosclerosis will progress. It has been classified under 6 categories, type 1 to type 6. Type 1 is the one which is very common, and type 2 also very common. Type 1 is the initial thing, that is where isolated foamy macrophages are seen within the tunica intima. Type 2, the fatty streaks are seen almost by the age of 1 year itself. We all develop fatty streaks where there is intracellular lipid within the tunica intima. So have a look of this diagram. So this is how the normal coronary arteries will appear on cut section. So fatty streaks are the one which are very common finding by the age of 1 year itself. So presence of fatty streak, don't think it is very abnormal. It is very common finding, especially in sections of aorta. These fatty streaks can further progress to fibrofatty plaques as the time advances, as the disease advances, as the atherosclerosis will advances. So totally the lumen can be totally get narrowed. There can be critical stenosis of the vessel can take place. So this is very much advanced or vulnerable plaque. So in type 3, it's an intermediate lesion where you see small extracellular lipids. In type 4, it is a classical atheromatous plaque where you see core of extracellular lipid. In type 5, it is a complicated form where you will see the fibroatheromas. Not only lipid, it will undergo fibrosis, it can even undergo calcification. The most complicated form of atherosclerosis is the type 6. So here there will be even associated other complications like hematoma development over the atherosclerotic plaque, hemorrhage can take place over the atherosclerotic plaque, and even it can predispose to the formation of the thrombus, which can become an embolus within no time. So remember, fatty streaks, don't think they are very abnormal. It is very common even at the age of around 1 year itself. All children older than 10 years will show fatty streaks in their cut section of the aorta. It all depends whether they will progress to fibrofatty plaques or they will regress. It all depends on various factors, modifiable factors and non-modifiable factors, what I told initially. So sometimes they will regress if there is a good physical activity and if there is no diabetes, no hypertension. Sometimes they may remain unchanged. So the fatty streaks may remain unchanged throughout the life. Progression is likely seen in the individuals who are exposed to the unfavorable environmental factors and what I told the risk factors as such. So the fatty streak is not the raised one. It appears as multiple yellow flat dots of less than 1 millimeter in size. They coalesce into streaks of almost up to 1 centimeter in length. It is composed of lipid filled with the foam cells, T cells and even extracellular lipid. The atheromatous plaque is very common in the abdominal aorta. Which portion of the aorta will show? It is above the bifurcation of the abdominal aorta below the origin of the renal arteries. So that portion of abdominal aorta is the most common site where you see the atheromatous lesions, and even aneurysms are also common at that particular area. So abdominal aorta is more involved than the thoracic aorta. Such lesions are more prominent around the ostia, opening of the vessels. Around the opening of the vessels, atheromatous plaques are very commonly seen. So it's the abdominal aorta, the first and foremost commonly get affected, followed by coronary arteries, followed by popliteal arteries, descending thoracic aorta, internal carotid arteries, as well as the circle of Willis. What are the major consequences of atherosclerosis? This is what you have to remember. What are the complications of atherosclerotic plaques? It all depends which organ is get affected, which organ is showing the atheromatous plaques. So if the coronary arteries are get affected, person will have a heart attack, what we call it as myocardial infarction. If the cerebral vessels are get involved, person will have a stroke. Aortic aneurysms are very common, especially in the abdominal aorta. Peripheral vascular disease, like patient can develop a dry gangrene of the lower limbs. It is again because the popliteal vessels may show atherosclerotic narrowing. Mesenteric occlusion, the mesenteric blood vessels may show occlusion by atherosclerotic narrowing. It can result in the ischemic bowel disease. Even in ischemic encephalopathy can develop. So see the beautiful gross specimen of coronary artery here. So this is a critical narrowing. So narrowing, if it is more than 90%, we call it as critical narrowing. Totally, there is no blood supply, almost there is no blood supply to the heart. So this, you can see the atheromatous plaque, which is appearing as a white or a pale yellow in color. So this is section of aorta, grasp suspension showing the atheromatous lesions. So at the opening of ostia, you will see plenty of deposition of these atheromatous plaques. So these elevated lesions are the atheromatous plaques. This is normal area in between. These are the atheromatous plaques. They appear pale yellow in color. So these are all atheromatous plaques. There can be area of associated hemorrhage. So microscopically what you will see is the fibrous cap on the both the sides, which is composed of smooth muscle cells and dense connective tissue. The cellular area, it will shows macrophages and smooth muscle cells and T lymphocytes containing the all these foam cells and smooth muscle cells, we call it as foam cells. And the central area may show deep necrotic center, which is composed of disorganized mass of lipid, cholesterol clefts, and even thrombus formation can be there. There can be an effort from the vessel to form new blood vessels, neovascularization can be seen. This is how the section of aorta will be seen under microscope. See here, this tunica intima layer, which is broadly widened, and it's all showing the atheromatous plaques. You can classically see the cholesterol clefts. So these are all foamy macrophages and foamy smooth muscle cells, So this entire lesion is the atheromatous plaque. So near vision of the same, here you can see the cholesterol clefts, needle-like structures, which are not taken any stain because the fat will get dissolved during routine tissue processing. So wherever fat is accumulated, it is appearing as empty spaces. So these are all cholesterol needles, cholesterol clefts. So diagrammatically you can represent like this. This is a tunica intima, foamy macrophages. These are the cholesterol clefts. And this is the smooth muscle cells. They will migrate to the tunica intima. So there are a lot of variations in the classical atheromatous plaques. Like sometimes they are typical atheromas containing abundant lipid. Sometimes they can be fibroatheromas, where more of smooth muscle cells and more of fibrous tissue will be seen. Advanced atherosclerosis is the one where fatty atheromas will be converted totally into the fibrous core, and they will have various pathological changes. At the end, remember the complications of atherosclerosis. Atheroma itself is having its own complications. A mnemonic I have made like this. A stands for aneurysm. Abnormal dilatation of the vessels is most important and common complication. T stands for thrombosis. Thrombosis can be developed and it can even become an embolism. The atheromatous plaques also may show areas of hemorrhages. Because of aneurysms, at any time they can rupture because the wall will be very, very weak. So aneurysmal rupture is again very common and grave complication. Occlusion of a lumen resulting in the myocardial infarction, which can result in the death. So this is the way you can remember the atheromatous complications. So try to read more and more about atheromatous changes, most important being the risk factors and the morphological changes. So I will tell in detail about ischemic heart disease in the next topic.